Yep.
Okay. So hi everybody, my name is Alex Ortega. I'm a second year student here at the KC campus. And today I'm going to be presenting a case report that I was a part of, which is dealing with esophageal perforation following a small bore nasogastric tube placement. For this case report, I worked alongside Dr. Dixon and Dr. Wessel down at the University of Kansas Medical Center. So I'll go ahead and get started. Let's see. Okay, so before I get started with the clinical presentation, I would just like to go over a couple key facts and statistics before we actually get started, just kind of set the background of the clinical case. So 70% of esophageal perforations are iatrogenic and can be caused by instrumentation, with NG2 being a very rare cause of the perforations, as we'll talk about here shortly. NG2 intubation is performed to provide early enteral feedings, medication administration, gastric decompression in patients who aren't able to tolerate oral intake. Um, and then esophageal perforations from NG2 placements are very rare, as I just mentioned, with only 3.1 out of 1 million cases reported annually. So not very common at all. And then a couple of risk factors include things like DKA, alcohol use, substance use, malnutrition, critical illness, and esophageal candidiasis. And then another key thing that should be mentioned is that um, these carry a high morbidity mortality rate. So it is really important to diagnose these as early as possible to lower that mortality rate and just have the best outcome for the patient. So now moving on to the actual clinical presentation, we had a 61-year-old male who underwent direct laryngoscopy, total laryngectomy, and esophageal dilation with complex closure for the laryngeal obstruction and tracheocutaneous fistula, which was secondary to the chemoradiation for laryngeal cancer. In our case, a corpac was placed intraoperatively and advanced at bedside postoperatively in a blind fashion. This is generally the case as NG tube intubations are generally considered a pretty safe procedure and there's not very much complications from them. So this wasn't anything out of the ordinary. So corpac placement was verified with plain film imaging, which is usually the case, and then small tube feeds were initiated. However, in our patient, he experienced acute onset abdominal pain and hemodynamic instability. Our patient didn't show a lot of clinical signs or presentation or anything like that, which makes it a little bit harder to diagnose the actual perforation. But we'll talk a little bit more about what can be seen in other cases later on. Then the CT scan demonstrated the corpac was penetrating or perforating the distal esophagus. And so an emergent surgical exploration was done, and during this exploration, the esophagus was evaluated via left-sided thoracotomy and was found to be injured distally, just inferior to the diaphragm. And then an upper midline laparotomy was made for intra-abdominal exploration, as well as a retrograde endoscopy via controlled gastronomy. The corpac was found to be penetrating the mucosa of the esophagus and running alongside the submucosal esophageal flap. In our case, the corpac was left in place to facilitate later identification during repair. The iatrogenic gastrotomy was primarily closed and a gastroduodenostomy tube was placed for enteral feeds. And this is usually part of the treatment for patients who have an esophageal perforation, just to get the nutrition in the patient, all that stuff. So this is also a key part of the treatment. The patient did require ICU level care following the procedure, and then the corpac was removed on post-operative day one at the bedside. His tube feeds were slowly advanced to go via the gastroduodenostomy tube, but it was prolonged by intermittent ileus with nausea, vomiting, and abdominal cramping. The patient was eventually discharged to an acute care facility, but has continued to require gastroduodenostomy tube feeds due to complete obstruction of his esophagus. So now moving on to the discussion of the case. NG tubes are passed through the nose into the stomach, duodenum, and jejunum, and are commonly used for enteral feeds, medication administration, or gastric decompression, as well as stomach lavages, as mentioned before. Then, to confirm the placement of the actual NG tube, an AP chest radiograph is usually the gold standard, and this was done in our case just to confirm the placement of the tube. This case does describe an esophageal perforation and a gastric perforation following NG tube intubation. And then esophageal injuries, as mentioned before, are rare complications due to NG tube intubations. And during my research, I wasn't able to find very many cases where NG tubes were causing esophageal perforation. So This is very rare, but especially distal gastric perforations, which is what our case was showing, and I wasn't able to find any of those during my research. So that's what makes our case a little bit more unique than the rest of the ones that I was able to find. And then esophageal perforations alone, as mentioned, have a high morbidity and mortality rate with 10 to 25% in the first 24 hours, and then jumping up to 40 to 60% uh, when treated beyond the 48-hour mark. So now clinical presentations can be nonspecific and can mimic other disorders such as pneumonia, angina, peptic ulcer disease, and pancreatitis. So this can make it a little bit more difficult to diagnose because you are thinking about those other things and not necessarily thinking about the esophageal perforations, which are not as common. So you just want to keep this in the back of your mind when you are presented with a scenario like this. So then symptoms that should lead you to be suspicious of an esophageal injury are things like pain in the neck, chest, back, or epigastrium, dysphagia, odonophagia, dysphonia, and dyspnea. And this is especially true when you are having a patient who had just had some instruments go down the esophagus, which could lead to perforation. So if you see these things, um, these these symptoms, clinical presentations following esophageal instrumentation, you should definitely jump or put that up into your differential diagnosis a little bit higher. And so then common clinical signs include subcutaneous emphysema, shock, pneumothorax, hemothorax, and fever, as well as tachypnea, tachycardia, and hypotension. Our patient didn't show a lot of these, at least not from what we could tell. It is mostly the hemodynamic instability and then the abdominal pain. And then physical exam findings can also include crepitus on the neck, chest, and face, as well as neck swelling, epigastric tenderness, nasal voice, or sometimes even normal findings, which can make it even harder to diagnose, increasing that mortality rate, which is not something that we would want in our patients. And then chest X-ray should be taken when esophageal perforation is suspected. And then things that you can see in the chest X-ray that could lead to early evidence of the perforation include mediastinal emphysema, free and abdominal air, or pleural effusions. Then once you suspect from the chest X-ray that there could be a possible perforation, you could do things such as a contrast esophagogram or a CT scan, which is what we did in our case, or what the physicians did in this case. And this can be extremely efficient in diagnosing early esophageal perforations when traditional clinical signs are missing, similar to what our patient had. So then move on to the treatments. This can include IV fluids, nothing per mouth, or broad-spectrum antibiotics, antifungals for any possible infections that could be the result of the perforation, proton pump inhibitors, narcotic analgesics for the pain, total parenteral nutrition, such as the uh, gastrojejunostomy tube that was used, and then decision whether surgical closure should be used or non-operative management. Surgical closure does remain the primary choice for treatment in cases of clinical instability, but other cases could have patients who are hemodynamically stable. So that's kind of gonna have to be kind of a case by case basis whether you want to do surgical closure or if you want to treat with non-operative management. And then all esophageal repairs should be drained by large bore intercostal tube, and then the feeding jejunostomy should be added for nutrition, such as in our case. And then there are new procedures that are being done to treat these esophageal perforations. Although I didn't find that these are very common yet, I think they do show a lot of promise and potential. But these can include endoscopic vacuum therapy, endoscopic stent placement, clip closure, suturing, and tissue adhesives. Surgical repair is the primary choice currently. So these are things that can be used and have been used, but not very commonly yet. So in conclusion, esophageal perforations are life-threatening conditions with high mortality rates, and they should be recognized early. Sometimes this can be made a little bit more difficult because the clinical presentation just isn't there. But if you can, it's best to really find these as early as possible and treat them. And then there are several iatrogenic causes of NG tube insertion or esophageal perforations, but NG tube insertion is a very rare cause, as mentioned before, with only that 3.1 out of 1 million cases reported annually. And then typical signs and symptoms sure lead to suspicion in patients who become susceptible to one. And this would be patients who have had that esophageal instrumentation recently. And then chest X-ray can be used to look for clues for potential perforation, and then either contrast esophagogram or CT scans can be used to confirm the diagnosis. In our case, a CT scan was used. And then surgical repair is the preferred treatment for those who have been diagnosed before 24 hours for best results. And then conservative treatment can also be effective, as mentioned before, for patients who have no clinical signs of sepsis or instability. And then here we have a couple images from our patient on the CT scan. So it looks like right here, it could be the possible perforation, maybe a pleural effusion on this left side. But yeah, these are kind of the images that we got from our patient. And then these are my references.